And welcome to another Video 3 Media Newsline. We're on location in Kilmarnock at the Dementia Resource Centre, where I'll be talking with Chief Executive of Alzheimer Scotland, Henry Simmons. But while I go and grab a cup of tea and a scone, let's have a look at what's coming up. Prestwick Picture House is a free community cinema organised by Dementia Friendly Prestwick. The relaxed screenings of classic films makes it an ideal day out for anyone and everyone. We'll be chatting with the organisers a little later. Pupils from Prestwick Academy and local primary schools took part in a Dragon's Den event to generate ideas to improve the experience of people living with dementia. It was a big yes from us. I also visited Teresa Douglas, project lead for dementia with NHS Education for Scotland, to talk about how staff can be more effective in their roles. As you can see, plenty to look forward to. But first, I caught up with Henry Simmons to talk all things Alzheimer Scotland. Enjoy. So thank you for chatting with us today, Henry. What is Alzheimer Scotland's overall vision in terms of dementia and dementia care?
Well, we've been working towards a very clear vision for the past probably 7 or 8 years, and it involves probably trying to ensure that we can transform our health and social care system from the very start of developing the illness, getting a diagnosis, to the very end. And across the past 3 national dementia strategies, we've been trying to make sure that the key elements of that are being addressed within each strategy. So the first one, from our perspective, was to try and ensure that when people receive a diagnosis, they receive that as early as possible and as timely as possible, and then they receive high quality post-diagnostic support. And we researched and developed a model that's called the 5 pillar models of post-diagnostic support. And what that does is it creates a platform of helping someone at the very early stages to really come to terms with the illness, to develop a network of peer support opportunities like you're hearing behind me, to then build their plans for the future and also deal with their sort of decision making. And the most important thing from my perspective is to try and ensure that people keep their life together, and all the things that they've been doing, they don't stop doing. So, you know, things like participating in your golf club, your bowling club, your book club, your church, your bingo club, things that really are perhaps the most important part of your life, we want to try and sustain, because we know that if we get all that right and we help people build resilience at that point, what you will then be able to do is to live pretty well for quite a number of years without the need for being admitted too early to things like residential care or formal day services. And that was all part of the first dementia strategy, and we got that tested. The second strategy, we looked at people who perhaps had progressed to the more moderate stages of the illness, and we developed a model called the 8 pillar model, and that looks at how you can coordinate far more effectively all the different aspects of a person's lives and their support needs when they progress to that stage of the illness. So things like housing, general health care, you know, other forms of therapeutic interventions, because people won't just have dementia, they might have other comorbid conditions. And what we really wanted to try and create was a role that would make sure that all of that is working in a unified way to support the person and to support their time living with dementia, but not putting all the pressure on the carer to try and join the system up, but for someone to really take control of that. So that was tested as part of the second dementia strategy, and it's really evaluated very well, and the key role there is dementia practice coordinator. So the next component for us was to work on the advanced stages of the illness, and we developed a model that relates to the 8 pillar model and tries to argue that when people progress to the more advanced stages, that what they require is not to be moved about or for their care to be sort of given in different places from where they choose to be, but to actually encourage the care to be brought to the person. And lots of people tell us through our engagement with them, particularly carers, that at the end of the time, you know, what they've been forced into is making decisions that they didn't really want. So things like moving from their house to a hospital, or from the care home to a hospital, and what we really want to see is people passing in a place of their choice with decisions that are made well in advance, supported by really skilled professionals. So that kind of gives you, from the point of diagnosis to the point of end of life, a very clear methodology of how we can support people better. Alongside that, the other work we've done is we've invested very heavily in developing our work within acute hospitals, general hospitals, and we've now got a nurse consultant that initially we funded along with Scottish Government, but are mainly funded now by the health boards themselves. We've got one in every NHS board, and they're a very strategic leader, and their role is to change the system to support people as they get admitted to the general hospitals, which is very, very common. And when people get admitted to the hospital, what we want to make sure is happening is that they're getting back home and they're getting supported in a way that actually helps them to really have a quality experience in the hospital and for it not to be a negative one. So alongside that, we've been very lucky that our partners in NHS NES and the Social Services Council have trained up to 700 dementia champions. We've worked with our colleagues at the Chief Nursing Office and the Scottish Government policy teams to develop 10 care actions. And what we've got within acute care is a very clear direction of travel about how we can transform the experience for people. And a lot of resource has been put into that, which is great. But we've also changed the way people think, because a lot of people don't realise, now the most common type of admission to a general hospital will be someone over the age of 65 with probably, either a dementia, delirium, depression, and quite a significant sort of new set of skills are required to develop there, and that's been positive. And then the last component of our vision is to develop as much dementia-friendly community activity as possible. And if you like, we're in an environment right now which exemplifies our desire to take dementia to the high street and to continuously do all that we can to destigmatise, to make it much easier for people to access information. And we've got a great digital platform in terms of our websites and social media, but lots of the people who want help from us, don't even want to use the phone. They want to come and get a face-to-face time, and this is the type of environment that we can deliver that in. So from our perspective, what we're trying to do is transform the journey, change the system, but change it through evidence, through high quality research, good partnership working, and at the heart of all that, we've been fortunate in Scotland to have the voice of people with dementia and the voice of carers driving all that we do. So from our perspective, the policy world and changing that world is one element of our work. The second element is to get help to people and to try and make sure that people have got support from our dementia advisors. We fund a network of advisors throughout Scotland. We've got a 24-hour helpline. We do a lot of work within individuals and communities and community activities. We provide a lot of support in terms of day services and trying to make sure that when the time's right for people to get and need access to formal services, what they receive is a high quality therapeutic service. And for people with dementia, that has to be a bit smaller, a bit more focused. It has to have a skill set that's really ensuring staff understand how to deal with the challenges and the issues that people are facing, and that we don't just simply put people into big scale services that really don't help tackle the symptoms of dementia. So
what does Alzheimer Scotland hope to see in terms of the next national dementia strategy?
So our work within that is we're a conduit at times to the voice of our members and to obviously ensure that people with dementia and their families and carers are being listened to. And I think that we've got really structured voices in terms of the Scottish Dementia Working Group and National Dementia Carers Action Network, who have really influenced the strategy very well. So the most important thing from my perspective in terms of the strategy is that it starts from the perspective of people with dementia and their families, and it starts from a rights-based approach. Now, from that point onwards, you then have to think what the strategy can achieve, and I think the strategy performs a really important leadership function in terms of highlighting what parts of our system we really need to change in order to deliver on the rights of people with dementia and improve the quality of care. So within the strategy this time we hope to see things like a further shift towards diagnosis being driven within a primary care context. So again, trying to encourage people to get an earlier diagnosis, and by that we'd like to see things like open access memory clinics taking place in GP surgeries. We'd like to see much more emphasis placed on people being able to take control of that and go in early and get at their, get an assessment of their memory and just get, a chance to sort of break down that barrier sooner. Because the quicker we do that, the more people's lives are intact and the better we can support people. So I think a shift towards primary care and diagnosis is the right step, but that will take some time because primary care is incredibly stretched and we don't want to add a burden to primary care, but what we want to do is try and ensure that the workforce behind that are linked much more to primary care. So then diagnosis. Scotland's the only country in the world that's made a commitment to support people, you know, in a really skilled way after diagnosis for a minimum of 1 year. And that commitment was made by the First Minister when she was Health Secretary. And we think that has been a really helpful way of ensuring the protection of support for people at that point of diagnosis. And I think that we need to refine that and develop a new set of standards for post-diagnostic support. But we've got something like 60 or 70 link workers throughout Scotland. It's an ongoing battle to get their funding secured. It's always very difficult to try and help people see the value of investing early, because there's such a lot of need out there and there's a lot of people in crisis, and I can understand it's not easy to say how do you put money into the system really early, but our kind of a hope is that we won't give up on that. And just to give you some of the figures, as well as changing people's lives, it probably costs between about £700 to £1,000 per person for post-diagnostic support, and our kind of argument is that will delay admission to residential care in some cases for 1 year or 2 years. Now, residential care will cost you about £30,000 per person per year. So the returns, not just for the person, but the returns for the system on early intervention are huge. So we really want to see diagnosis shifting towards primary care, emphasis on post-diagnostic support, and then I think that we really would like to see the concept of dementia practice coordinator rolled out, because our members tell us all the time that, you know, the families, the carers, they're coordinating everything, and you get some teams that do really well with perhaps the health aspect or the social care aspect, you know, but you don't get some, you know, experiences where everything is getting dealt with by one person. So the psychiatrist, the GP, you know, the housing, the community connections, all of these things, if they're coordinated really well, you really help people live well for much longer. So we'd like to see that driven forward. And lastly, I think that we've moved quite significantly in our understanding in terms of our advanced model, and we'd like to see palliative care and, you know, better support for people at the point of end of life being really well understood, and not just sort of like, you know, like, we're not saying throw lots of resources at it. I think we need to understand it. We need to understand the change in the illness. So as people progress to the advanced stages, it becomes very much a physical set of needs that are required. We would like ultimately for that to be people receiving that without having to pay for any aspect of it, but that's not part of the strategy. That'll be part of our campaigning work. And I think that there's a lot of work that we need to do within that end of life to ensure we deliver the best quality care for people in the fairest way.
So how important is a human rights-based approach to dementia, and what does this mean?
I think it's probably the most significant transformation in thinking about someone with dementia, because, and I think that what you need to be really careful of is it's really easy to say it. So everyone says, oh, that's a human rights issue, it's a human rights-based approach, and it's like, you know, but it's incredibly difficult to transform the system to allow our way of working to be a human rights-based approach. Okay, so things like, you know, it sounds choice, power, control, you know, the right to privacy, to a family life, the right to life, all the things that are fundamentally already embedded in law haven't been delivered to people with dementia, despite the fact they've been in law for, like, you know, many years. So we've had probably like areas where you could question the human rights of, like, you know, overuse of antipsychotic medication, you know, like inappropriate detention, inappropriate sort of like levels of support, inappropriate levels of like help to live a private life or an independent life, a lack of choice, power and control. Now that's probably 10 years ago where all of that was at its peak. From our perspective, like, to take a human rights approach is that you really are starting very much to say, this is a person, they've got a diagnosis of dementia, but they've got a whole set of rights to begin with that we need to respect, and then not just give things to them from our system, but give them choice and power and control within that. And then when they no longer have the ability to do that, to ensure that they've empowered someone who will represent them either as a power of attorney or a guardian to ensure that their rights are delivered. But the system has to flex and change to deliver a human rights-based approach, not just say it. Yeah. So by Scotland having a human rights perspective, which was founded in our work in the Charter of Rights, 2009, I think that we've got the right function, but the structures to deliver that require an awful lot of transformation and work. And it's a big challenge for our really significant bureaucracies to be personalised in that way. And I think that if we do that, we'll really transform the lives of people with dementia and their families and their communities. But we've some way to go to achieve it, and that's our main drive.
So can you tell us about the work Alzheimer Scotland is doing in terms of helping build the Dementia Friends programme?
Yeah, so the truth about the Dementia Friends programme is that it's been tried and tested in a number of other countries. Our colleagues down south, they were quite inspired by what happened in Japan. And Japan is a very important sort of area to look at, because in Japan the demographics here are very similar to where we'll be in 10 years. So they started the programme and it worked incredibly well, and they started it down south, and quite high aspirations to recruit 1 million Dementia Friends. And they were doing it for about a year before we started to think about it, and it just seems to work really well. We fund it in Scotland, and we decided to fund it because we just like the idea of people making a commitment to come to learn more about what it's like to live with dementia. It's not a training programme, it's not like a course, it's an experience where you'll learn more about dementia, you'll know what it's like to live with dementia, and then you'll make a commitment to do something positive to support people with dementia, to support the movement. We now have something like 33,000 people in Scotland have signed up as Dementia Friends. I feel that's just remarkable. Now all of the people are telling us and telling the Scottish public, we want to do something to really support people with dementia. And even just by wearing the badge, they're doing something, because it's breaking down the barriers all the time. And if you can imagine, we now can communicate, probably because of the advances in terms of our technology and digital platform, as I mentioned earlier, with 33,000 potential individuals that want to be part of our force for change. That's a lot of people, and that permeates out beyond the 33,000 people. So we're really keen that this becomes part of that evolution of citizenship, this evolution of change, this real embracing within Scotland and across the UK of people willing to do something. Now they've got an opportunity to do something. I think that they're embracing it, whereas in the past we made dementia very special, and we probably left it, we took it away from people in everyday life, and it was held to be something that only professionals and skilled people can do something about. So you absolutely need professionals and skilled people, you need that part of the system, but we've got to make that jump back the way to say, well, actually, don't be that worried about supporting people with dementia. Don't be frightened by it. Engage with it, embrace it, and this programme really helps with that.
So I think you may have covered this a little bit already, but how important are the dementia nurses in the NHS, and what role do they play?
Yeah, I touched on that a little bit earlier, but just to go through it again, the area where we heard so much difficulty for a number of years was within our acute general hospitals. Now, what was unknown at that time, if you imagine that within the hospitals, that if you had a, say, 900 bed hospital, which is a big hospital, probably 300 people within that hospital would have some form of dementia or other forms of cognitive impairment. And the staff within that environment, when they trained, they never expected to be working with people with dementia, and they weren't trained to work with people with dementia. So what we have been trying to do for the past 8 or 9 years within the acute care is to help the staff learn new skills and to understand that their day-to-day work now will involve supporting people with dementia, not just in a sort of small way, but in a big way. Now, what was previously prone to happen was that because people with dementia weren't normally in the acute admission wards, and if you imagine a medical ward or a surgical ward, the person with dementia would often get moved, or they might be very distressed because they weren't perhaps receiving the right level of care or support, And when they're distressed, there's not a lot of staff there who know what to do, so there'd be an inclination perhaps to use medicines to help the agitation. And none of that is very good. And what that sometimes leads to is the person can be a bit more distressed or more confused. And what we know through research was that at that point in time, people were often getting decisions made about then going to residential care. And there's a cycle starts, so the person doesn't go back home, they're going to go to residential care. There's not been many plans made for that, so the person ends up in a delayed discharge. They then could be moved from ward to ward as they're waiting to get to residential care, and the system's not really working well when it's behaving like that. So what we've tried to do through the nurse consultants is to get really, very skilled, very experienced, senior professional nurses who understand dementia to analyse the systems within each of the boards and the hospitals and start to transform it. Now, alongside that, we've partnered with the University of Western Scotland. We've been commissioned with NHS and Social Services Council to train dementia champions. That's a very skilled piece of work. That's not like a 1 hour programme. That's a 6-month period of study, and it's blended between on-site training at university and then action, engagement within the actual wards and environments where people work in order to transform the environment and create change. We've now got something like 700 dementia champions. So we've got 46 general hospitals, big hospitals, with 700 dementia champions. We've got 14 nurse consultants, and we've got behind that these 10 care actions, which all the hospitals are working towards. We've got the chief executives and the chairs of the boards buying into that. And I feel what we've managed to create is a map there that really can transform that, really large part of our system. Now, if we can get that right, what it will mean is people can have a really good admission, really positive experience when they're in the hospital, be well supported by people who understand how best to look after their needs at that time and get back home again and not get caught in that cycle that I described earlier. So it's hugely important work.
Can you tell us about the hopes and aims of dementia research?
Yeah, so we really are very interested and very keen in terms of dementia research. And if you imagine, one of the sort of philosophies of our organisation is to ensure we get the right care today, but that we continue to search for a cure tomorrow. And I think that from our perspective, it's not good that we're probably 15 years away since the last time we had any drug, maybe even longer, maybe 20 years now, any new drug. And if you think there are only 4 medicines at the present time that are prescribed for people with Alzheimer's disease, and none of these drugs affect the disease process, they don't modify the disease process. So we're sitting with perhaps one of the biggest public health and social care issues of any kind, with very little in our, if you like, medicines to help treat that. And our knowledge in terms of research, I think, has been evolving all the time. So we probably are in a place now where if we had hundreds of millions of pounds to spend 20 years ago, we probably wouldn't have known where to target it. But you have to go through that process. You have to spend lots of money in the research journey to then get to an area where you say, well, actually, that's probably the right playing field to be on. We're at that playing field now. I think we know where the key targets are. Our colleagues in sort of like, the research community are much more sort of like, clued up on where they want to target and what they want to do. Now, what we need is investment to take that to the next level. And I think that Scotland is perhaps one of the best countries in the world to act as a basis and platform to develop dementia research for a number of reasons. First of all, we've got some of the best universities in the world with some of the best researchers, but also we've got great data and cohorts, we've got great information on people, and we've also got a scale that we can really test and trial new innovations and new drugs. But also, I think that through the work of colleagues like Craig Ritchie, John Starr, Edinburgh, who we work very closely with, we've got the ability to perhaps really look at areas such as prevention and to understand the factors that will help prevent huge numbers of people developing dementia. And that's as equal a goal as trying to get a treatment. The more that we can do to prevent people, and that's only going to be done through research, then the more that we can really avoid people developing dementia or developing it early or too early, and then really helping our system get the right type of care in place as people progress. So the future in terms of dementia really requires investment, it requires direction, it requires collaboration to the extent that perhaps, like, you know, we're starting to see in Scotland, and can really be built up to progress beyond, I suppose, just universities competing with each other for money,
Yeah.
to collaboration to really target the areas that we think we can prevent or develop new drugs within.